Good morning. I'm very honored to be here with you today to present around the utility of MRI in the newborn intensive care unit. We're going to cover a few basic topics to try and understand the utility of MRI. First, touching on the tool, the MRI machine, and the images that you will see. Secondly, we will look at the application of MRI in the term infant, focused mainly on hypoxic ischemic encephalopathy. And finally, we will look at the application of MRI in the preterm infant, particularly around that of brain injury and encephalopathy. So MRI has many strengths, as we'll discuss, but there are also challenges. The strengths are that it is the best anatomical delineation of brain structure and injury that exists, and that there are multiple different complementary sequences, as they are called, that provide insight into either structure or into potential stress or injury in the brain. But there are challenges. It often requires transportation at a distance from the NICU. It requires the infant to lie still, which for many means sedation, or for us, we have perfected being able to wrap most of our infants to keep them nice and still during the scan. The scanner needs to be optimized, so radiology need to be invested in this with you. They need to help your scanner be driven appropriately for babies, because the way we use the scanner for babies is slightly different from the way we use the scanner for adults. And you need to optimize the way you can get the information acquired from babies' brains. And finally, you need expert interpretation of these scans. And again, this requires a radiologist who's really dedicated to learning and understanding how to read the MRI scans. So what does an MRI scanner produce? These are the types of images that you will see coming from an MRI scanner. You can see on the top line here, there is a so-called T1 and T2. And many times people get kind of torn up about these different initials and letters, and there's too many pictures and the MRI looks too complicated. So just remember, T1 and T2 is kind of like 1 and 2 when you're counting. These are the basics. These are the way to look at the structure of the brain, and they're in a way kind of inverse to each other. In other words, in T1, you can see all the fluid in the ventricles and around the brain is black, and the brain itself is white. And in T2, the fluid, the CSF, is bright white. And I often think of that as a good acronym, too bright, that's T2. So the CSF is bright and the brain is kind of black, right? The different tissues of the brain. But you can see a lot of brain structure here because you can see the so-called cortical ribbon, the gray matter of the cortical gray matter wrapped around the outside of the brain. You can see the somewhat less contrasted but present white matter that's present. You can see in the middle the kidney-shaped structures of the deep basal ganglia, the deep nuclear gray matter. And you can see those areas that stand out as contrast are actually myelination. Those are very important, as we'll see. So you can see a lot of structure, even on one slice. You can see, is the cortex intact? Can I follow that little cortical ribbon all the way around? Can I look at the intactness of the white matter? Are there any holes or bleeds or gaps? I can look at the deep nuclear gray matter, as we'll see, as to whether there's any injury there. I can also look at how the brain was formed. Are there two normal hemispheres? Are they well folded? And we'll look at that a little bit with the preterm. So these are really the kind of foundations of what MR provides in terms of structure. You can see on the lower panel, there's a degree of blurry images, so-called DWI and ADC. This is diffusion weighted imaging, and it's a map that comes from the diffusion called the apparent diffusion coefficient. Now, why do they look so blurry? Well, in traditional MRIs like T1 and T2, we are vibrating a proton and we're looking for the resonance back from that proton. In diffusion imaging, we're resonating a whole water molecule. So the whole water molecule has to move and move back, and then we try to track it, which is just actually really mind-blowing to think we can even do that, but it's why the resolution is not as fine. So if you see blurry images come up like that, either the baby's moved, which isn't ideal, or these are so-called diffusion weighted images. And the way we acquire the raw data is called a diffusion weighted image. That's one you see on the left. And what we're looking for injury in is any area that's bright white. Now, because sometimes the amount of water that's in the brain can affect how water moves around the brain, we correct that sort of basic amount of information by a sort of a way of getting rid of some of the changes that might be just structural water. And when we do that, we generate this map called the apparent diffusion coefficient, which is meant to correct for those difficulties and allow us to really see if water movement is being restricted, or there's been problems with local brain swelling or with brain cell death. And when we see that, there's big black areas, as we'll see on the apparent diffusion coefficient. We also have another type of imaging called susceptibility weighted imaging, and this is really looking for blood. And so these will show up as big black areas if there is hemoglobin or hemosiderin present. And finally, some MRI scanners will generate a so-called MRS, or an MR spectroscopy. This is brain chemistry, and it just looks like a whole series of mountain peaks, but each mountain peak relates to a particular molecule that's important in identifying brain structure and sometimes brain injury. So often around so-called 1.1 parts per million, we'll look for a lactate peak to indicate that the brain may have been under anaerobic stress. So how can we apply this in the term infant who may have encephalopathy? What we want to use the MRI to help us know is when and whether any injury occurred. And this may help us in the future to understand whether cooling is the right strategy as more and more different types of therapies become available, particularly stem cells, where we can't administer both stem cells and cooling at the same time. It may also help us in understanding when injury occurred, and this is obviously particularly relevant within the United States, where litigation is a major problem. It can also help us in decision-making around whether to continue ICU care in the setting of an infant who's severely affected. And this is challenging because it may require the transport of a very unstable baby off the unit to acquire these images. And finally, perhaps the most important thing for the majority of these babies, particularly if they've received hypothermia treatment, is to be able to diagnose what the nature and extent of any brain injury is, because this will predict the prognosis for this infant long term. So MRI in the early period, particularly the first 24, 48 hours, is really driven by identifying injury with diffusion imaging. And it's a very important technique and used for stroke in adults. It represents both necrosis and apoptosis, the two main measures of cell death, and it evolves over many hours in the first 24 to 48 hours. And it's very important that you know this. As I said, you can get these varying different types of images off the diffusion weighted image. And most of the time, what I would encourage you just to focus on is the so-called diffusion coefficient ADC map. Now, when we take the direction of water movement with looking at how the water is moving, we can also generate maps that give us fiber tracts, because water will move along a fiber tract only in a very limited highway. I'm on the highway, I can't get off, I've just got to move up and down, up and down. And we can look at these by so-called anisotropy maps. And this is the lower one that shows these bright white fibers for the optic radiations, posterior limb of the internal capsule and the corpus callosum. And we can color these by the direction that water's moving. So green is back to front, blue is in and out, so going down to the spine, and red is left to right. So that helps us to know how the fiber tracts are looking and if the fiber tracts are looking intact. Now, as I said, diffusion changes evolve because cell death evolves. So we have studied this in two different cohorts. The first was a cohort of babies who were not cooled. And when we looked at that, you could see that the peak time at which you could see the injury or that the diffusion coefficient was lowest was around 48 hours. And then after that, the diffusion started to so-called normalize. So if you imaged out around day 5, you may not see a lot of diffusion imaging changes in a baby who was not cooled. And certainly by day 7, it was completely gone. Diffusion was not worthwhile. Now, cooling has changed that slightly. And now when we image in the cooling period, the fall is still about the same time, peaking at around 48 hours, but there's a much longer time to pseudo-normalization. So over this period, you may not see it as prominently as you would around 2 to 3 days, but you'll still see pretty prominent restriction and diffusion in areas of injury, suggesting that the injury is actually going on for a much, much more protracted period of time, perhaps giving us the opportunity for further neuroprotection. So this is what it can look like. This is a baby who was got severe brain injury, who was imaged on day 1. And you can see not anything to see on the T2 imaging because there's no abnormality. You may be able to see that you're worried a little bit on the apparent diffusion coefficient about some restriction already in both of the thalami and in the hippocampi, right? This is the hallmark of very profound central brain injury. But look what happens by day 5 now. We've started to see some fading of the cortex and the gray matter signal in the deep nuclear gray matter. It doesn't look completely normal, but it's not 100% easy to diagnose. Whereas look at the diffusion now. You can see this baby did undergo hypothermia. You can see all of the basal ganglia now are deeply dark, deeply restricted, as is all of the perisylvian cortex. And in fact, on the DWI, everything just about lights up. And some of this is secondary so-called Wallerian degeneration. And again, a slice lower now, you can see the hippocampi, very abnormal. Again, here from pre-cooling times, really going back now nearly 15 years. At 16 hours, just a bit of restriction on the ADC map and a little bit of lactate. But by day 4, very prominent lactate on spectroscopy, very prominent abnormalities seen here on the diffusion and really faded by 8 days. Can't really see those diffusion changes. Now you can see the very prominent changes on the T1. So when we look at the evolution of injury with MR following an acute hypoxic ischemic insult in the infant brain, we know that the first 24 to 72 hours are predominantly negative on conventional scanning, but that between 24 and 72 hours, we will see this restriction and diffusion, which will persist through the first week of life, potentially with some anisotropy changes. The conventional changes will start to occur between 5 to 7 days, but they won't be very prominent until the second week, really, or the third week. So it's really around 10 to 14 days, you'll see more established abnormalities. And then after 14 days, you'll start to see the atrophy. That led the American College of OBGYN to try and bring in some imaging recommendations around their new guidelines for understanding the pathway to neurological outcomes in neonatal encephalopathy. And they said that head ultrasound was useful and should be used in the first day. CT shouldn't be used due to its poor sensitivity and the risk. And MR on day 1 to 4 is useful for delineating injury on diffusion and helpful for estimating timing. But follow-up imaging, really, if you get to do 1 scan only, I would strongly encourage you to do it between day 7 and 21, preferably around day 10 or 14, because you are going to miss some evolution of injury because that injury is still evolving, as you could see on the hypothermia study. What do you see when you look at the imaging? The 2 commonest patterns are the cerebral deep nuclear neuronal injury that we looked at and the so-called watershed or parasagittal brain injury. Here's an example of a parasagittal injury. So you can see here now on the DWI, this restriction here in day 4 in the posterior watershed and a little bit in the anterior watershed. Nothing to see on the T2s, whereas by day 10, that's faded. And now you can see a little bit of high signal, but it might have been hard to pick it if you hadn't have had the earlier imaging. Deep nuclear grey matter injury, as we said, is also very common, and as you've seen already in some of the cases, it's been looked at as to how to better prognosticate around the use of deep nuclear grey matter injury. And what we know is that mild injury may just involve focal injury in one area here in the lentiform, moderate involving both the thalamus and the lentiform, severe with this very deep injury to all of the lentiform. The head of the caudate is the most likely area to be spared. And so it's often the area I use as kind of a control area when I'm looking at the brains to see whether the signal is abnormal. Because if the head of the caudate has got this coloration, shows you everything else, apart from the posterior limb, the internal capsule, which you can see here is intact. That posterior limb of the internal capsule runs from the corticospinal area in the brain all the way down through the spine for important motor neurons. And it's one of the early areas to myelinate to allow the baby to feed. So you can see here two beautiful myelinated posterior limbs of the internal capsule. Here you might think they're kind of trying to be there, but they're definitely impaired. And here completely absent. So instead of the bright in the posterior limb, you have a complete dark, and you instead have the brightness in the surrounding areas around the basal ganglia. So normal, impaired, or absent plaque, mild, moderate, or severe deep nuclear grey matter injury. So why does this matter? As we've said, this plaque is very important to detect. It matters because it's been studied to relate and help you in talking with families about prognosis. So mild basal ganglia injury, we often think of as mild, but in fact, 10 to 15% of these children will go on to have cerebral palsy, although it'll be at the milder end. The ability of them to walk and their motor function can be well kind of correlated with the presence of myelination in the posterior limb of the internal capsule. If that's present and normal, they will be walking at 2 years. If it's equivocal, there may be a late start or even some impairment after they do get walking in terms of clumsiness. The other types of difficulties that children with basal ganglia have do occur, but not commonly. 10% will have feeding difficulties, 25% later speech and language. Don't forget that around 10 to 20% of these kids will have impairment in intellect. And whether seizures occur really depends on involvement in the cortex. What happens if we go a degree more severe into moderate basal ganglia injury? These children never have a normally intact plaque. They always have equivocal or abnormal plaques, and the likelihood of cerebral palsy is high, greater than 50%, although if the plaque is trying to be present, it hopefully will be mild. They also have a lot of other disorders start to occur, feeding difficulties, speech and language, vision, and developmental issues. That leads to the severest form of basal ganglia injury, which is universally associated with spastic quadriparetic cerebral palsy, which is mostly very severe. And these children have an overwhelming burden of multiple disabilities. And the delineation of this on imaging can really help a family to make decisions and plan for what their wishes are for their child. How good is MRI at predicting these outcomes? It's actually very good. You can see whether you're cooled or non-cooled. It has very high sensitivity, pretty good specificity and positive predictive value, and a very good negative predictive value if the scan is unremarkable. And you can see how well, even for a positive predictive value, these compare to, say, a chest X-ray for pneumonia or pleural effusion, which you wouldn't question. So very powerful. Particularly powerful is this posterior limb of the internal capsule myelination for motor deficits. So you can see here that if the plaque is normal, these children will walk and do not develop cerebral palsy. If it's abnormal, the vast majority of these children have abnormal outcomes. And the only children who didn't had alternative sort of pathways to why their myelination may be impaired by having other types of white matter injury. MRI is also good at picking up other etiologies for neonatal encephalopathy that may not be just classic hypoxic ischemic, but particularly arterial ischemic stroke. Commonest time in life to have a stroke is the first week of life. Commonest time for a stroke to be missed, first week of life. And you can see here the prominent abnormality regionally in this distribution here on the posterior area for the diffusion weighted imaging, the apparent diffusion coefficient. And you can see the amount of cortical swelling that's occurring with the loss of the cortical ribbon on the T2. And this imaging was undertaken 4 days after the infant presented with seizures. So in summary, for term encephalopathy, I think imaging is evolving to be able to tell us when and whether injury occurred. And this may guide us as time goes by in understanding whether to call or not. For instance, if you had access to an MRI scanner early and you could delineate by imaging in the first 12 hours that an infant had established injury, you may decide that calling is not likely to be beneficial and instead wish to offer stem cell therapy. It may also help with litigious inquiries. It can certainly help if you have a very severe infant, because you may be able to make early decisions for this family if you see, for instance, severe basal ganglia injury, to considerations of redirection of care for the family. It does, however, often require the transport of an unstable infant off the floor to the scanner, and that can be challenging. And finally, the most powerful part of MRI for the term infant is the diagnosis and prognosis in the setting of encephalopathy, to be able to really understand, as we've talked about, what the pattern of injury is to predict outcome. So with that, I'd like to move to MRI in the preterm infant and talk about the application. I'd first like to reinforce that we have a long way to go in the preterm infant. Therapeutic hypothermia has helped us tremendously in the term infant, but we have not had an advance like that in the preterm infant. We know that 5 to 10% of our preterm infants still have a risk of cerebral palsy, with nearly half having increased clumsiness and reduced physical ability. 1/4 to just under half of our preterms require educational assistance in school, and 1/4 develop behavioral problems, including ADHD, social maladjustment. Have our outcomes, tended to be similar across different gestational ages and across different cohorts? And this was data that was published looking at America, Swedish, and United Kingdom outcomes in our very preterm infants across a broad range of gestational ages, as you can see here. And obviously, how immature you are does drive your risk. The chances of having no disability as a 22 to 23 weeker is essentially less than 50%. Whereas as a 26 weeker, you've got only about a 25% chance of having significant disability. So those are outcomes at 2 years of age, but what about at later times? Do they catch up? Well, actually, this is beautiful data from Australia looking at 3 cohorts within Victoria studied. And what you can see is that at 8 years of age, still many of these children are identified as having significant difficulty with deficits in IQ in around 15% of infants less than 1,500 grams now, with significant difficulties in word reading, spelling, and math, and motor issues. And importantly, these haven't improved over time. So even though we've been doing all the things, we have been trying to improve neurodevelopmental outcomes, if anything, we've seen a slight increase in difficulties with math and motor impairment. And in the same regard with executive functioning in particular, we've seen elevation in the number of children who seem to be exhibiting difficulties in executive functioning. So we have a problem with the preterm infant, and how can we understand, particularly when it comes to prognosis, what pathways might be driving these adverse outcomes? And to do that, we have to be able to delineate fully brain injury and alterations in brain development. Brain injury is multi-type in the preterm infant. We often recognize on cranial ultrasound intraventricular hemorrhage, But cerebellar hemorrhage is also very common, particularly co-bedding with interventricular hemorrhage, and often much harder to diagnose, even with good cerebellar views with the ultrasound. White matter injury is the commonest form of brain injury in the preterm and most difficult to see on ultrasound. And then even for MR, there are so-called invisible forms of brain injury that are occurring in the cortical neurons that we need to really try and have better techniques to delineate. Part of the gap between understanding what happens in preterm birth and outcomes relates to brain growth and the fact that we haven't centered ourselves on formally evaluating that. And finally, for both the term and the preterm, there are key factors that influence the translation of MR as a tool. So for the preterm, I really think MR has a role in defining the presence and severity of any brain injury. And this parenchymal involvement may be able to assist in decision-making, such as very extensive parenchymal bleeds or grade 4s. For the future, however, there will also be opportunities for neuroprotection, early white matter injury delineation and sepsis and neck, and neurorehabilitative therapies such as stem cells and growth factors being offered to our preterms as well as our term infants. Things like erythropoietin, things like combining that with stem cells. And then how can we better target rehabilitation? If we know there's been brain injury at any other time in life, we always offer and target rehabilitation. So let's start with interventricular hemorrhage. And you can see here are 3 babies with so-called grade 4 interventricular hemorrhages. So when the grade 4 diagnosis comes back from the cranial ultrasound, everybody lays the black crepe and people feel very, very sad. But each of these lesions is not the same. And the way I try to explain this with families is to talk about stroke. And I talk about the grade 4 as a brain stroke, and that all these strokes are different sizes, and therefore they have different outcomes. So not all grade 4s are bad. Many can be very focal and have pretty good outcomes. And that was shown here by Linda DeVries's group when they did this beautiful series of over 200 infants with so-called grade 4. They looked at the distribution of them. And as you can see, the vast majority of these lesions lie in the parietal area. And of those children that survived, and about a third of them did not survive. So those were obviously infants that probably had a much larger burden, a much larger stroke lesion. Of those that survived, only half had any form of cerebral palsy. And the vast majority of that was mild upper limb cerebral palsy or upper limb cerebral palsy. So these children were ambulant. They needed therapy for their upper limb, but this was the predominant outcome for these focal lesions. In contrast, if the parenchymal hemorrhage involved the frontal or the temporal lobe, these children were much more likely to have more complex behavioral and cognitive impairment. Cerebellar hemorrhages are often unrecognized. In cranial ultrasound studies that have been carefully done with good cerebellar views, around 2 to 8% of preterm infants are said to have them. But when it's compared to MRI, in our very preterm infant, below 1,500 grams, the incidence is much higher at around 15 to 20%. Smaller cerebellar hemorrhages, such as you see in this MR here on the far left, are often only seen on MRI. So you can see all these multifocal punctate lesions here. This is a much larger focal unilateral hemorrhage, and on this image you can see extreme severe bilateral hemorrhage. Larger hemorrhages are known to be associated with cognitive, language, and behavioral problems. And this is the meta-analysis that was recently published that looks at the relationship between cerebellar hemorrhage and outcomes. And you can see for both cognitive and motor abnormalities is about a 3 to 4-fold increased risk. But the vast majority of this is driven by the large hemorrhages. The smaller punctate hemorrhages to date do not appear to have these correlates, although we continue to follow the children. White matter abnormalities are the commonest form of brain injury in the preterm, and they can take many forms, from cysts to these punctate lesions that you can see here distributed, loss of white matter volume, or diffuse high signal. And what does that look like? And you can see here 4 grades of white matter injury shown. Either these subtle punctate lesions, so-called grade 1, more severe punctate lesions, particularly when they lie in line with the posterior limb of the internal capsule, much more likely to have impairment on motor function. And then these 2 more severe forms, linear scarring or cysts from infarction, are rarer these days, but do still occur. This is a very busy slide, but let me walk you through it. These are the 4 forms of brain injury that we have sort of touched on: IVH, white matter injury, cerebellar hemorrhage. We haven't talked much about the cortex, but I will at the end. When you think about germinal matrix and intraventricular hemorrhage, the vast majority of this is very visible on cranial ultrasound and has been shown to relate to neurodevelopmental outcomes, particularly in high grade, grade 3 and 4, and particularly if it's complicated by post-hemorrhagic ventricular dilatation, which can benefit greatly from serial measurements of the ventricular dilatation and preventing severe ventricular dilatation. So really, MRI can help in delineating a little extent, but cranial ultrasound is going to be the backbone of defining this type of brain injury. In contrast, white matter injury needs to be defined by MRI. You can see that there is the ability of cranial ultrasound to see cysts, which obviously is associated with the risk of cerebral palsy, but each of the other forms of white matter injury are pretty poorly delineated by ultrasound and require MRI. And in all of these cases, the white matter injury has been associated with an increased risk of neurodevelopmental disability. The same is true for the cerebellum, where large hemorrhages can be detected by ultrasound, but it can be challenging. And certainly they are strongly associated with adverse outcome. But milder, smaller punctate type lesions aren't. And finally, for the cortex, really, MRI is still evolving in terms of being able to develop that. And we do believe that probably is one of the key mechanisms by which we see many of the cognitive and behavioral difficulties in the preterm. But at least we can evaluate brain growth with MRI. When we compare cranial ultrasound and MRI for predicting neurodevelopmental outcomes, you can see these are all the studies that have looked head to head. And again, it's a busy slide, but I would just get you to focus on 2 things. The first is that almost always the black color, which is the MRI, shows higher values than the pale color. In other words, MRI is better at predicting long-term outcome. The other point I want to make is that if the MRI is negative, that's the so-called negative predictive value, or shows that there's no abnormality, it's very, very prognostically powerful. So if you have a negative study, in other words, no abnormality detected, for those parents to know that the likelihood their child will have any neurodevelopmental disabilities is extraordinarily low, lower than the term-born baby that might be being born healthily in the labor and delivery that day. So MRI can be important in delineating injury and also very important in reassuring families that no injury exists. When we look at all these different studies, it's very important to understand that each of them has used different ways of looking at the MRI. So not every MRI comes out automatically with like a report card of what you see. Many times people have used methods to try and delineate the white matter injury, and each of these has been different. And the 2 studies that have shown the least correlation with MRI used their own somewhat unusual scoring system, shall we say, to delineate injury. The MRI studies that have shown the best prognostic value, such as the ones at the top of this study, used combinations of both the presence of injury and the evaluation quantitatively of brain growth. Despite that, after these analyses and a meta-analysis that was beautifully presented in pediatric research, the summary was that term equivalent MRI has a high predictive value for cerebral palsy and motor function impairment, independent of early cranial ultrasound and other factors. And this alone should be a reason that we implement it and start using it. As I said, you can add to that if you add these additional measures of brain growth. And what do I mean by that? You can take simple calipers on your MRI and measure a so-called measurement of biparietal diameter to look at brain growth, and a measure of interhemispheric distance to look at the gap between the hemispheres to show impairment in brain growth and development, as is shown in this image here, in an infant that was born extremely preterm. Brain growth is important because you could monitor it during the NICU stay using these brain measures, these brain metrics or brain volumes. And we know now that brain volumes are altered by things we do. They're altered by exposures such as opiates, which reduce cerebellar volume. And we know that high negative and low positive experiences such as parent presence and touch and nurture also appear to be influencing brain growth and development. We also know that nutrition affects brain growth and development, and that poor breast milk exposure and low lean mass relative to high fat mass can affect brain growth as well. So improving protein and calorie intake and reducing fat intake may improve brain growth. So this meta-analysis recommended in an algorithm here the utility of MRI by applying it universally to all infants that were less than 1,000 grams or less than 29 weeks, and then selectively, if the infants had any abnormal physical exams, any evidence of encephalopathy, any unexplained abnormal neurological behavior, a history of sepsis or NEC, then selectively infants up to 32 weeks would have those images undertaken. But this is vastly different than what most places around the world are doing at the moment in terms of giving access to MRI. So why is that? Why are we hesitating to provide light on the extent of brain injury in our babies? One of the messages that's come across was led by strong parent advocates after their twin daughters were born at 25 weeks in Canada. They noted that their baby had a very stressful NICU course as she lost her sister. And MRI in this unit was undertaken as routine care for infants who were less than 26 weeks. In Marin's case, a moderate cerebellar hemorrhage was diagnosed on MRI that had not been seen on cranial ultrasound. And the parents found this very distressing, as the way in which they discovered she was having an MRI was coming in to see her and finding she wasn't in her crib space without any other explanation of why an MRI would be being ordered. And when she came back, they were just told by somebody that this hemorrhage had been found, but they were not really debriefed and counseled about the meaning of this. So instead, they went to the computer, to Dr. Google, and found concerning information about adverse outcomes with cerebellar hemorrhage, but without being able to put in context the size of Marin's. However, Marin went into aggressive early intervention and has done well. Her parents therefore feel that what they went through was a lot of pain for no gain, because they describe a tenuous link between MR results and outcomes, and some parents would prefer to remain blissfully ignorant, especially if there's nothing medically tangible that can be done. So a very nice trial was carried out by David Edwards' group in the UK, where infants underwent both an MRI and a cranial ultrasound at term equivalent. The babies were randomized for their parents to receive either only the brain MRI result or the cranial ultrasound result in a structured interview from an experienced physician unaware of the result. And they were given some summary information about the prognostic information. And the primary outcome was maternal anxiety, with the premise that MR may elevate maternal anxiety. And what did they find? They actually found that maternal anxiety did not go up after the MRI, but actually went down to a greater extent, and that certainly at 12 months it remained lower in the infants whose parents had received information on the MRI. So it reduced maternal anxiety to a greater extent, although we're obviously, as we have alluded, still learning how to use the information. And it was also better at predicting motor outcomes in cranial ultrasound, though neither was good at predicting cognitive outcomes. In the United States, a group of neonatologists under the American Academy of Pediatrics decided to discuss what they regarded as wise or useless treatments. And one of those treatments that they decided was not wise to undertake was a routine MRI or discharge MRI. They stated the findings on term equivalent MRI correlate with neurodevelopmental outcome at discharge at 2 and 5, confirming what we've just said. They said, however, there's insufficient evidence that routine use of an MRI improves outcome. So no study has been done on that. And most importantly, going into an MRI machine will not in itself be a treatment. It's information that then guides treatment. And it relies on the clinician being able to take that information and guide treatment with the family. And so beautifully, Donna Ferrero responded to this, saying that MRI at term equivalent in preterm infants really is the wise choice, that the Choosing Wisely campaign concluded there was insufficient evidence. And unfortunately, the authors were confused between prediction and outcome. No one is claiming a scan alone can improve outcome, but rather performing the scan allows one to decide on necessary interventions that improve outcome. Therefore, despite the well-intentioned guidelines provided by the Choosing Wisely campaign, the preterm newborn who is at high risk of brain injury should have proper documentation of their brain status by MRI prior to discharge from the neonatal intensive care unit. Does early intervention make a difference? Does it help if we identify injury and put extra rehabilitative help in? Well, of course, that study, as I said, has really not been done, but what has been done is look generally at early intervention programs for preterm infants, which vary greatly in their content, but they have all shown a trend towards a strong positive influence on cognitive and motor outcomes during infancy, with the cognitive benefits particularly persisting into the preschool ages. What we think is that future research is really needed to determine which developmental interventions are going to be most effective, and particularly to turn that in a targeted way. So I've identified white matter injury, challenges with the plaque. I know motor outcomes are going to be a challenge. Let's get that input in sort of early and focused on physical therapy and motor function. Part of the other reason there's been delays in implementing MRI in the preterm infant, I still have to believe, is our difficulty as clinicians in having these conversations with families. If we don't look, we don't have to talk about it. And it really is challenging when a baby has come through a really tough, long course. Their parents are anxious, and then you're going to have the MRI scan and give them additional knowledge and information that you may not feel comfortable conveying to them when you've been the one reassuring them that all the cranial ultrasounds were negative, rather than the word I don't think should go with cranial ultrasound, which is normal. So it's important that we look at ourselves and try and skill ourselves in having good conversations about what we know, what we don't know, but how we can support this family. And as you can see, the families found with greater information from the MRI that they were more empowered. So whether it is a term baby or a preterm baby, the application of MR in the newborn provides detailed methods to define brain injury and growth. And that access, radiology partnership, monitoring and quality all matter. Experience in the interpretation by the radiologist is critical and needs to be a commitment you make together, as is how this information is transmitted and shared with families in a caring and supportive way. And all neuroimaging is only as good as you when you write the order about what you are looking for, the acquisition of the MRI scan optimized with your radiology team, the radiology interpreter of the scan, and you as the communicator at the neonatal bedside. Our infants and families deserve to have definition of their discharge brain status to assist in risk stratification for very limited rehabilitation services, so you can apply the right services to the highest risk infants for the right reasons. And with that, I thank you for your attention. I hope you're having a great meeting, and I wish you all the very best in the coming year.